Hello, everyone, and welcome to our Cancer Education Series. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and founder of Above and Beyond Cancer. And tonight we're going to talk about genetic testing and genetic counseling. And our guest is Lauren Winter. Welcome, Lauren.
Thank you.
Lauren grew up in Illinois, went to high school in Illinois, and then got her bachelor's degree at Iowa State. Also stayed on and got a master's degree, and then did her genetic counseling master's at the University of Pittsburgh. And she joined the MercyOne Cancer team in 2020. So tell us, when did you first get interested in genetics? Did you have an idea in high school, or was it classes you took in undergrad that led you that direction?
I really was interested when I was in high school. And the long version of the story is that I've grown up around the cancer world. So a very close family member was diagnosed with cancer when I was about 5 years old. And I spent a lot of time kind of in and out of that treatment center with her as she went through her cancer journey. And so medical information was available to me from a really young age. So throughout that whole thing, I came to understand that there were a lot of careers besides being a doctor that could lead you into medicine and into healthcare. And that was really kind of what struck my interest when I was looking into careers. And then a biology class in high school just really made me fall in love with genetics. So finding out that there was something that I could do that combined those two things and that there was a healthcare career in genetics was really what sold it.
And when you were looking to where you were going to go to college, did Iowa State have a program, or in their first 4 years, it's basic science?
First 4 years are a little more basic science. So genetic counselors have a background that's very, very varied. Biology, sometimes psychology, sometimes we'll even see somebody who has like a marketing background and is looking for a career change. I've got friends in that realm. But I majored in genetics and psychology because I was pretty sure that I knew what I wanted to do. And Iowa State does have a genetics program. So I was able to get that experience early on.
And some people might wonder about psychology, but we're going to talk about there's two aspects, more than two, but there's at least two.
Mhm.
I mean, there is the science of the genetic testing, but then there is the counseling with the counseling. And that's obviously a human being talking to a human being, and psychology has to be pretty helpful in that aspect of
Certainly. Genetics impacts family members, and there are some short-term and long-term effects, and it can change what people understand their perceived health risks to be. And there is caregiver psychology and support to be given, and you really are in a supportive role. So having the psychology background is also really valuable.
Mm-hmm. So you got your bachelor's degree at Iowa State, and you said your major was genetics and psychology.
Yep.
And then you stayed for a master's at Iowa State, and that master's was in?
It's in biomedical science.
Okay.
And that really gave me some strength in understanding more of a pre-medical kind of field. A lot of my colleagues went on to doctor programs, both medical and PhD doctor programs, as well as some veterinarians, because it was through Iowa State's veterinary medicine program. So I have a lot of colleagues that were pre-medical professionals in a lot of realms there.
And then at the University of Pittsburgh, that training program was specifically geared towards you coming out as a genetic counselor.
Correct. Genetic counseling is a specific master's level training program that someone has to complete in order to be eligible to sit for a board exam to be certified as a genetic counselor.
And was that training a combination of classroom and being in the clinic and getting experience doing counseling?
Definitely. So there's a lot of straightforward lecture in medical genetics and how the body works and molecular level, as well as some lecture about psychology and doing that as well. And then a full year that's dedicated to just being in the clinic and practicing those skills on real people.
Mm-hmm. And not unlike being trained as a nurse or a doctor, where you learn the book stuff, but you need to also learn how to actually practice the trade with real patients. Before we start talking about the genetic testing and genetic counseling, maybe compare and contrast a couple of things, because nowadays we do a lot of testing on the tumor cells themselves. And we use a term that ends up being confusing to patients. So we talk about genomic testing of the tumor. So you can send in a piece of the tumor, and we can test the genetic makeup of the tumor cells, and also some of the surface proteins, and other characteristics of the tumor cell. And we often call that genomic testing, but that is testing the characteristics of the tumor cell. So contrast that to genetic testing. And what are we testing when we do genetic testing of an individual?
So tumor cells are inherently different from the rest of our cells that make up our body. That's what makes them become cancerous, and that they grow without control by the rest of our body's regulation systems. So genetic testing for hereditary cancer syndromes looks at the DNA, the genes in our cells, the cells that we were born with that haven't changed over time.
Our normal non-cancerous cells.
Right.
And we use a phrase for those cells in the body.
Somatic, so of the body. And we also have another term called germline. So germline is where the information is able to be passed on. So the genetics of a tumor can't be passed on to somebody in the next generation, but something that is germline can be.
Yes. So that's another phrase that's confusing, because in the lay term, we think of a germ as like a bad bacteria, but this is more along the lines of germination.
Yep.
And it's the cells that propagate and go into the next generation. So we can either call it genetic testing of somatic cells or of the germ line.
Mm-hmm. Yep.
Okay? And so when did we first understand genes? I mean, Watson and Crick, and then the whole idea of how genes are spread to the next generation.
Yeah, I think in general, we understood that things could be inherited before we knew what DNA did. In the 50s is when Watson and Crick and Rosalind Franklin described the shape and structure of DNA. And then from there, it really took off, where we were able to understand how that was crucial to our body systems.
Yes. How many cancers in the population? This year we're going to have 1.7 million new cancers in the United States. What percentage of cancers do we think come about because of abnormalities in our genetic makeup?
Statistically, about 5 to 10%. So 1 in 10 to 1 in 20 people who develop cancer will have a hereditary cause for it.
And the abnormality that probably captured most of the population's interest in it is the discovery of the genes that lead to a higher risk of breast cancer. Mm-hmm. And if anybody's heard of genetic mutations, they've often heard of the BRCA gene. There's obviously many other genes, but that is the gene that many people have heard of, and many people know that, okay, breast cancer is one of those cancers that can be come about because of a mutation in our normal cells that predispose someone to cancer.
Right. We all have the BRCA genes. There are 2. So they're actually named for the type of cancer that we discovered them increasing risk for. So BR stands for breast, CA stands for cancer. We all have 2 copies of BRCA1, and we all have 2 copies of BRCA2. Our understanding is that their normal job is to act like stop signs to tell the cells not to grow. So if there's a mutation in one of those genes, that's when someone has a higher chance of developing cancer, because the BRCA gene's not working to do that as well.
So what makes you suspicious that a woman who's been diagnosed with breast cancer may have a genetic predisposition?
Certain things like a younger onset. So most women who develop breast cancer will have gone through menopause. So women, the cutoff that we use to define is under 50. So someone diagnosed under 50 with breast cancer would be suspicious that there was something that they were born with, like a gene mutation that was increasing their risk for cancer. If there's a strong family history in combination with that, so if we see those breast cancers in multiple generations of the family, that can look less random than seeing 1 or 2 women in that family with breast cancer. There are certain features of the breast cancers themselves that could make us think that they are genetic versus random. Most breast cancers are at some level influenced by the amount of hormones, the amount of estrogen that a woman's body makes. And so if the tumor does not display receptors for those hormones, that can lead us to think maybe there's another cause and maybe it's the gene.
So a woman who is postmenopausal, let's say 65 years old, and has the most common form of breast cancer, estrogen receptor positive, progesterone receptor positive, HER2 negative, 65, no family history of cancer. The likelihood that it is because of a genetic mutation is exceedingly small.
Very small.
Yeah.
Mm-hmm.
When you meet with someone, let's say a woman who's been diagnosed with breast cancer, what does that initial interview, the counseling before you get to the point of testing, what does that consist of?
So we go through and talk about goals that person has for why they might be motivated to do genetic testing. I'll take a full family history looking at least 3 generations of their family tree on both sides, both mom and dad's sides, because we get genes from both of our parents. And so we'll talk about any patterns or features of hereditary cancer syndromes that we see in their family and what we think the likelihood might be.
I suspect that having the conversation with them probably prompts them to learn more about their family history. So before they have cancer, if you say, okay, what's your family history? They, might certainly know their parents. They may not know all their aunts and uncles, and they probably don't know all their first cousins' history. But once they're diagnosed with cancer and they're meeting with you, you prompt them to get some more information.
Yeah, a lot of times we'll get started and I draw this out in a family tree as we're talking, and people will really dial in and really be interested in thinking about, oh, I'd really like to know. So we can fill that in for those other people in the family. And it does become a really cool collaboration that we get to work on together.
And one of the reasons that you go through the history is obviously it tells you what cancers were in the family. So if you're looking at a hereditary and there's no history of cancer, that's kind of a clue that it isn't hereditary.
Yeah.
But there's a certain level of family history that is significant. So part of it is, how many family members do you have?
Right.
I mean, do you just have mom and dad and grandpas and grandmas and there are no aunts and uncles, so that the whole denominator of your family is small,
right?
Versus having 10 aunts and uncles on each side and 100 cousins. What's the difference between a first degree relative and a second degree relative? And how do you put that information together to determine whether you think there's a significant enough risk that they have a hereditary cancer that makes it worthwhile to do the testing?
Sure. A lot of that is very nuanced. To answer the second part of your question first. So if we see enough of the same kind of cancer in first, second, and third degree relatives, that will start to look like a pattern. A first degree relative would be someone's parents, their full siblings that have the same mom and dad as them, and their children. A second degree relative would be a half sibling, an aunt or uncle, or a grandparent. And then a third degree relative would be like a first cousin. So any of those people having similar kinds of cancer can contribute to the same pattern in the family that I talk about with someone.
So let's say that the person you are counseling is less than 50, has breast cancer, and a first degree relative, mother that had breast cancer. Would that be significant enough to recommend getting tested?
Yeah. Seeing those 2 breast cancers and 2 women, kind of 2 steps in a generation, and 1 woman under 50. So that's the cutoff that we use for considering it young. That would be enough to say that experts recommend genetic testing. So we would go through that and kind of talk about what that person thinks of their risk. A lot of what I do is very motivated both by science and expert opinion, but also by the patient's feeling and how this information would work for their life and what their goals are for getting this information.
And how would knowing that you do have a mutation of the BRCA1 or BRCA2, how could that significantly affect the patient and the treatment that they might receive for their own cancer, let alone information that might have implications for the next generation?
Certainly. So talking about the BRCA gene specifically, in the average population, most women have a 1 in 8 or 13% chance of getting breast cancer in their lifetime. The risk for a woman to get breast cancer with a BRCA mutation is between 60 and 80%. The risk for a woman who's had breast cancer to get breast cancer again in the other breast is also over 50%, compared with about 11% in the general population. So because of that motivator of that higher risk, there are things we can offer along the way. Those women might consider a more extensive surgery than just having the breast tumor removed. They might consider something like a bilateral mastectomy to remove both breasts, which would reduce the risk of developing another breast cancer quite a bit.
So whenever we have a patient and they're being tested, and there's a couple of competing interests here. So there's the interest on the part of the patient and the doctors to move forward quickly with the treatment. But as you mentioned, if the patient does have a BRCA mutation, they've got a significantly higher risk of developing a second cancer in the future. And you may want to consider not just a lumpectomy, but actually removing both breasts as part of the breast cancer treatment in order to reduce the risk of a future breast cancer.
Yeah. And I also find that a lot of women who come to talk to me know about that option already, but another option that they don't always know about is that women who have a higher lifetime risk for breast cancer can also pursue increased breast cancer screening every year. So for women who have breast tissue who don't have that surgery, in addition to their yearly mammogram, can also have a yearly breast MRI and alternate one of those two things every 6 months. So there's 2 different images being taken of the breast every year to compare to each other, with the idea that if a breast cancer develops, it's going to be caught at an earlier stage. So there's something kind of at every stage of the game for somebody who's working with a higher risk for breast cancer.
And that high risk, obviously, if a woman with breast cancer has a BRCA mutation, and then her daughters get tested, and her sons, because we'll talk about other cancers, even without cancer, they would fall into the high risk category.
Yeah.
And at our breast center, we have a different way of following and doing the screening. As you mentioned, you would not just do regular screening mammograms, you would add in some other tests, including MRI. So when you have a high
And they
risk,
can also start younger.
Other implications for the family members that
Sure.
don't have cancer.
For family members that don't have cancer, they could also, be identified as having other types of cancer risk, both for the patient and family members. So that's another thing that we can consider, kind of in line with the current treatment plan, as well as after treatment is over, what other cancer risks do we need to prioritize as helping that you wouldn't have otherwise known about?
So you have a family that clearly has a BRCA mutation. What are other cancers that family members are at risk for besides breast cancer?
Having a BRCA mutation is also known as hereditary breast and ovarian cancer syndrome. It was historically and primarily understood that it increases women's risk for breast and ovarian cancer. We unfortunately don't have very good screening measures for ovarian cancer right now, so truly the recommendation for women with a BRCA mutation is to consider having their ovaries removed as early as age 40, so a little younger than natural menopause, but balancing that risk of early menopause with the increasing risk for ovarian cancer. Men with a BRCA mutation also have an increased risk for breast cancer, and most men aren't routinely offered breast cancer screening at their yearly exam, but men with a BRCA mutation would be. They also have an increased risk for prostate cancer, so another common cancer in the population, but BRCA positive men have a higher risk of more aggressive and metastatic prostate cancer. So that's also something that we would be diligent and even start their prostate cancer screening a little bit younger.
Yeah. So as you mentioned, men can get breast cancer. Typically, we don't screen men that are at average risk for breast cancer. But if a man has a BRCA mutation, you can do mammograms on men and other imaging if they're at high risk. And I imagine, I don't know that I've ever taking care of a gentleman who had prophylactic mastectomies because of a genetic mutation. I'm sure that does happen sometimes, but I've not personally been involved with that.
I think it would be a case-by-case basis. Most of the time, men are recommended to have a clinical breast exam done by someone who's highly trained. Men who are larger or might have more breast tissue might be recommended a mammogram. I think it would be a case-by-case basis for a prophylactic surgery.
And as you mentioned, men with a BRCA mutation are also at higher risk for developing prostate cancer. So screening at an earlier age for a gentleman who has BRCA mutation would be appropriate. Any other cancers that fall into that BRCA mutation leading to an increased risk of other cancers besides
Yeah.
breast, ovary, and prostate?
There are a couple. So both men and women have an increased risk for pancreatic cancer, especially with a BRCA2 mutation. Pancreatic cancer is another type of cancer that we unfortunately don't have great screening for. There's some things that we've been developing along the way, and then the recommendations are if someone has both a mutation in the gene and a family history of pancreatic cancer, that they can consider a couple of different screening modalities, including like an upper endoscopy with ultrasound or MRI. And then the last one is melanoma, particularly uveal melanoma. So we also recommend
And
people to
that's
stay on top
melanoma
of their
of the back of
eye
the
exams.
eyes.
Mhm.
That's the uvea.
Yep.
Uvea.
Yep.
So those are all BRCA related.
Mhm.
So would you say that breast cancer and screening for genetic mutations related to breast cancer is the number one type of cancer that you talk to patients about?
I do see it quite a bit. It's the one that we've understood the longest in terms of genetic testing, and it's in the risk for cancers, especially with the BRCA genes. About 1 in 400 people on average have a BRCA gene mutation. There is actually a hereditary cancer syndrome that is more common that not as many people know about, and that happens in about 1 in 280 people in the general population, and it's Lynch syndrome,
Yes.
also called hereditary non-polyposis colorectal cancer syndrome.
So Henry Lynch was one of my teachers. I went to medical school at Creighton, and Henry Lynch recognized that there were multiple family members over different generations that had colorectal cancer, and just started collecting those, more or less collecting the histories and putting it all together long before there was the actual ability to test for the gene mutations. And so that syndrome bears his name, the Lynch syndrome. So tell us a little bit more about Lynch syndrome. What genes are you looking for? And what are the cancers that individuals with those genetic mutations are more likely to develop?
So the 5 genes that can cause Lynch syndrome are MLH1, MSH2, MSH6, EpCAM, and PMS2.
Okay.
The primary risk for someone with Lynch syndrome is colorectal cancer. Most people have about a 5 to 6% chance of getting colon cancer in their lifetime. And with a Lynch syndrome mutation, that risk can be anywhere between 20 and 80%. The other 2 risks that we think about most often are women's risk for uterine and ovarian cancer. There are a laundry list of other digestive system and urinary tract system cancers that are also involved with Lynch syndrome, as well as some specific skin and brain cancers.
And does the risk of developing cancer with Lynch syndrome vary depending which of those 5 different mutations they have?
It certainly does. The risks are highest in MLH1 and on the lower end with EpCAM and PMS2. But the risks do vary, especially in the other digestive system, like the pancreatic and the small bowel cancers amongst those genes, but they are overall highest with MLH1.
And as you mentioned, Lynch syndrome is actually more common than the BRCA mutation. Under what circumstances, when you're counseling someone, let's say someone's just been diagnosed with colon cancer, what's the history you're looking for, and how, under what circumstances would you recommend they undergo genetic testing?
Again, looking for multiple generations of colon or uterine cancer in the family, and especially that younger age under 50. Pancreatic cancer, again, because it's less common, if we see that in the family, that will also contribute. And then for the patient themselves, their tumor can have really specific markers. So the genes that we're talking about here are hereditary cancer genes, are genes whose normal job it is in our body to protect us against cancer, and they make specific proteins. I call them recipes for proteins. So every colon cancer tumor is screened for 4 proteins. And if any of those proteins are abnormal, it could be because the gene that made them was abnormal. They have the same name, MLH1, MSH2, MSH6, PMS2. So if the end product comes out abnormal, we go back to think maybe it was the gene that was abnormal to begin with. So if someone's colon or uterine cancer tumor has those abnormalities, that will lead us to suspect that maybe there's an underlying hereditary cause for the cancer.
And if someone's been diagnosed with colon cancer and they don't have genetic abnormalities, what's their risk for developing a second colon cancer? And then conversely, if someone's developed colon cancer and they have Lynch syndrome, what's the risk that they will develop a future colon cancer?
I don't think those risks are particularly defined very well. Not all of the Lynch syndrome genes change management, which is kind of the interesting thing about them. So for some of the higher risk ones like MLH1, someone might be recommended to have a more extensive colon surgery, up to a total colectomy. But for most of the Lynch syndrome genes, what's recommended is for people to have their colonoscopies more often. Colon cancer is very preventable. So having a colonoscopy as frequently as every year with an MLH1 mutation, or every 3 years with a PMS2 at the other end, having a colonoscopy more often and having a polyp removed is a great way to prevent it from becoming colon cancer.
But as you mentioned, with the highest risk, sometimes it is the risk of developing future cancer so high that the surgery is different, and they opt for a total colectomy.
Correct.
And so getting back to managing patients, again, you've got these competing interests of wanting to move forward quickly, but we need to wait to see what are the results of the genetic testing, because that could change the surgery that you actually do.
Yeah.
So we've mentioned that a couple of times. How long does it take to get the genetic testing back?
It typically takes between 2 and 3 weeks to get the results back. And then I call every patient individually. So hopefully they answer their phone the first time. And then it's right about 10 days, sometimes towards the 3-week mark.
The first time you meet with them is a counseling session that assesses the risk based on family history and the type of cancer they have. And then counseling as to, if we were to do the testing, well, what would we do if it's positive? What would we do if it's negative? What are the implications? And after that initial counseling, if they decide that they want to do testing, you often will do the testing right there on the same day as the initial counseling.
In most scenarios, we can do it in the same day. There will be some instances where someone might have already had blood drawn that day and not want to have another blood draw, or they might have had chemo that day and they might not want to produce a saliva sample if they have a dry mouth side effect. Some patients who have a leukemia or lymphoma or received a blood transfusion will need to have a different kind of sample taken. So we can't send a blood-based sample for someone who has a blood cancer or a blood transfusion, and we'll have to set up an appointment with their surgeon to get a skin biopsy. So we'll send a sample of skin, because all of our cells in our body have the same DNA. So we can send multiple different things. But for the most part, we can do testing the same day that we go over our counseling.
So you mentioned 3 different ways of testing. There may be more, but you mentioned a saliva sample, you mentioned a blood sample, and you mentioned a tissue sample, like a piece of skin. Under what circumstances would you use? Obviously, you talked about the leukemia and somebody who's had a blood transfusion, and that might lead to wanting to do a piece of normal skin that you can get the genetic information. What about the difference between doing a blood test versus a saliva test for someone that you're suspecting might have a BRCA mutation or Lynch syndrome?
A blood test and a saliva test have the exact same accuracy. So for most patients, if we can choose one, we can choose the other as well. It's really up to patient preference what they decide to do that day. So it's nice that we have 2.
Well, it seemed to me that if you get spit in a tube, even though drawing blood is pretty innocuous and not particularly painful, that doing the saliva would be the preferred. But yet I see a lot of people getting the blood test. Is it that you have to produce so much saliva that is not possible for some people?
It's about a tablespoon of saliva, and for some people that is really difficult. As I mentioned earlier, for some chemotherapy regimens, dry mouth is a side effect. And so we're working with cancer patients, and so we have to acknowledge that is a truth. Some people, and it's very valid, have a preconceived idea that they can't let go of, that blood is going to be more foolproof. And I can appreciate that. So that is okay. We do a lot of blood draws in our facility.
And obviously, when you send out the saliva, they're finding cells from the lining of your mouth. So they're not testing the saliva, the mucus, but within our expectorated or spit is our cells from the lining of the mouth, and that becomes the source of the genetic testing.
Yep.
Okay. So then you get the results back. So you would have already met the patient, done counseling in person. They get the results back. Is the next session usually on the phone then?
Usually, yeah. Most patients are going to have a negative result and don't want to come in to go over not a lot of information. So I do call everybody. I let them know that I have the result. They always have the option to tell me if that's not a good time or if they would prefer to come in person once they've thought about it. But I will go over what their results are once we've established that it's a good time for them. And I do follow up with them. They get a letter written to them in the mail that's specifically to them about everything that we talked about, summarizes all of the things. And their doctor that sent them to me and anybody else on their cancer team that they want can have a copy of that too. So everybody gets the same documentation to be on the same page.
And do you find that most of the patients, since they've already met you, they know you, that they opt for the second visit to be on the phone?
A lot of times, yes.
Yeah, especially if it's a negative result, and there's not a lot of additional information to impart. If it's positive, then they may want to have a face-to-face because there's more implications.
Yeah. I've offered and I've had people take me up on the in-person visit for a large number of scenarios. So after we go over it on the phone, as you just said, someone might want to come in and just hash out what all those next steps are. Some people, take their notes and then they want a family member to hear the information as well, or they want to have me meet a family member that this result will impact. And so they'd come for a joint session to just kind of go over what this would mean for the family. So there's a lot of different ways that I do kind of follow up and have more meetings with people at their own preference.
And if the individual that you have tested and now is positive and they're the first person in their family to be tested, then there's a lot of conversation around who else in the family should be tested.
Certainly.
Siblings, children.
We'll often offer testing to parents as well to see which side of the family that gene mutation is coming from. But any parent, sibling, or child would have a 50% chance that they have that same mutation and cancer risk.
How does that conversation go? And do the siblings or parents or children come in for that counseling?
I think it depends on the family. A lot of times I'll see siblings, especially if they have multiple siblings or multiple of the same gender family member that have the same cancer and they're concerned about their own risk. I'll see a lot of children. A lot of the big motivation that I find that my patients have for doing this testing is to give this information to their children. So I do see a lot of that next generation coming in to kind of establish what this looks like for the rest of their life.
And then you're talking about the children, so that can be very delicate. Let's say the child is 5, 15, 25. What would the conversation be based on sort of those small child, sort of adolescent, adult?
Yeah. So for adult children and even for some adolescent children, I'll have a very open conversation with them. One thing that we can rely on is that children who are in high school now or, adults in their 20s and 30s had genetics education in high school. I've presented a genetics presentation to third graders. So more and more we're getting this genetics education as our biology younger. So this isn't the first time these kids have been presented with this idea. So for anybody over the age of 18, we can offer them testing. We can't offer testing younger than age 18 because it's an adult onset condition, the cancer risk is. So we want people to be over 18, be adults, be making decisions for themselves as adults. So I will have a conversation with a 15-year-old about kind of setting the stage, introducing the idea, and being a resource for them, separate from their parent, if they want to have more questions answered. For a 5-year-old, there are very few exceptions where some of the cancer risks do appear in childhood. So really, in my practice, that's about the only time that I would be seeing and talking with a child about this information.
Okay. So we've talked about the benefit that can be derived from doing genetic testing. What are some risks involved with doing genetic testing? And how has maybe some of those risks been mitigated by the Affordable Care Act, but what risks still exist by finding out that you have a genetic mutation?
One of the biggest things that people are concerned about is insurance discrimination. The Genetic Information Non-Discrimination Act, is affectionately known as GINA, was passed in 2008 before the Affordable Care Act, so when Bush was still president. And that law says that someone's health insurer and their employer, if they have more than 15 employees, cannot discriminate based on this information. So they can't use it to raise your rate or drop you. It can't be treated like a pre-existing condition. That law does not apply to any new policy that someone would take out in their long-term care, life insurance, or disability. So those types of insurance, a new policy could do a medical record review, could ask for this information, and eventually raise someone's rates or adjust their premiums. It's not a guarantee that they will. Some patients, find that they have the experience of having cancer, and so that's already what's kind of complicating those new policies for them. And so having all of the information is most important to them. But it is something different that I talk about at different life stages with people.
So let's say theoretically, the sister of someone who had breast cancer was tested and is BRCA positive, but does not have cancer. So, a review of their medical record, they don't have cancer, but a review of their medical record finds that they are BRCA positive with a much higher risk of having breast cancer. Under what circumstances could they have to pay a higher premium for health insurance? And under what circumstance might they have to pay a higher premium for life insurance?
It is illegal for health insurance to change that rate.
So for health insurance, it should not affect their health insurance premiums by having a genetic mutation. But life insurance,
there's no protection against that adjustment.
So that could be a reason that maybe a sibling or a child doesn't want to get tested right away, and maybe get your insurance first if you're thinking of getting insurance, so that
I have definitely had people do that exact thing.
Because you don't want to answer falsely on an application that has significant implications. But if you can honestly say you don't know if you have a genetic mutation. So we talked about breast cancer, and we talked about BRCA genes and all the different cancers that can be related to BRCA. We talked next about Lynch and specifically colorectal cancer. Tell us again, what other types of cancer do those individuals who have Lynch syndrome, are they at risk for besides colorectal cancer?
The next highest risk that we see is the uterine or endometrial cancer risk in women, followed closely by ovarian cancer. And then we'll also see stomach or gastric cancer, bladder cancer, small intestine, pancreatic cancer, prostate cancer in men, a specific kind of brain tumor, and a specific kind of skin cancer. All of those cancers being some varying degree of common in the general population. And for some of them, the risk in Lynch syndrome might be up to 8%. So still a 92% chance that someone's not going to develop that kind of cancer, but overall higher than the average person. The uterine cancer risk can be between 16 and 60% for women with Lynch syndrome.
So someone who has Lynch syndrome but doesn't have cancer, it would have implications on how frequently you screen them. And you might even consider having a prophylactic hysterectomy.
Many women eventually are recommended to have a risk-reducing hysterectomy and salpingo-oophorectomy to remove the fallopian tubes and ovaries as well. Again, because our screening is very limited for those.
So we've talked about BRCA, we've talked about Lynch. What would you say is another mutation that is more common than some of the other rare mutations?
One that is fairly common in the population is a mutation called CHEK2. And about 1 in 64 people have a CHEK2 gene mutation. CHEK2 is what we consider a moderate risk gene. So we've talked about genes that have this over 50% up to 80% lifetime chance of breast or colon cancer. CHEK2 has increased risk for breast and colon cancer, but both of those are about 2 to 3-fold the general population. So if we're thinking 12% in the general population for breast, a CHEK2 mutation carrier might have a 20 to 40% lifetime chance. Those women are still recommended to get increased breast cancer screening, but not always recommended a prophylactic mastectomy. The same thing with colon cancer, where most people have about a 5% chance of colon cancer. Someone with a CHEK2 mutation has about an 11% chance. So if they also have a family history of colon cancer, they would be recommended to get their colonoscopies more on the 5-year range instead of the 10-year range.
And fortunately, now that we recognize those risks, more and more high-risk clinics are being set up. So specifically at MercyOne Cancer Center, we have a high-risk breast clinic. We don't have as formalized clinics in the gastroenterology clinics, something that we need to work on so that individuals who've been told at high risk, that we have the ability to consistently screen them more frequently
Certainly.
and make sure that that they get the screening at a more frequent rate. What other types of mutations would you like to inform us of?
The list goes on. The largest panel that we order has 84 different genes on it. We've talked about different kinds of cancers, and that's really how we set up the panel. So the panels, there are about 28 genes that we know that increase someone's risk for breast cancer, about 20 for colon cancer, about 12 for pancreatic cancer, about 20 for ovarian cancer, and there's overlap with those. There are certain kinds of thyroid cancer that have a high risk of being genetic. So I can see a lot of different people throughout the week or throughout the month that will have different kinds of cancer.
But you don't do the complete human genome on every patient that comes in.
No.
You selectively decide which genes. And over time, over the last 10 years, we know more now than we did 10 years ago. We test for more genes now than we did 10 years ago. So someone who has a family history of cancer, who had genetic testing 10 years ago and was told, you don't have any mutations, should you periodically have another genetic test done because now we test more genes?
Yeah, that is a recommendation, especially if there are new cancers that get diagnosed in someone's family. It's worthwhile to just have a sit-down conversation and have that family history talked over one more time. That's especially true for things like breast cancer and pancreatic cancer. We're learning a lot more in those realms with pancreatic cancer than we ever knew previously about its genetic components.
So, Lauren, why should I go to all the rigmarole of getting an appointment with you, spending an hour talking, spitting in a test tube, then waiting 10 weeks? Why don't I just get 23andMe?
23andMe doesn't test any of that. So 23andMe works, their technology works the exact same way, but certain labs have clinical certifications where they are able to test and report on clinically actionable genes. 23andMe is not one of those labs. They have FDA approval to report on 3 specific BRCA mutations that are common in a certain Ashkenazi Jewish population, but they don't look at the whole BRCA gene. And so if someone with cancer is really concerned about their personal and their family history, a test that you can pick up at Target is not going to tell you the information you want to know.
They might tell me I had Irish ancestry, but they're not going
Right.
to tell me if I've got a genetic mutation that's going to lead to cancer.
They can tell you if cilantro tastes like soap to you.
Okay.
But you can probably tell that yourself too.
Okay. So conversely, so you're doing genetic testing to learn about the risk for cancer. Do you get information about those other things that 23andMe report on? Like your father is not your father.
Good question. So we don't get any reported genetic data back that's not about cancer. However, if we do test multiple people in the same family, we can get a report that says the relationship between these people is genetically different from what was reported, meaning that non-paternity or someone's biological father is not the person that they were told they were. Happens.
So that's a different conversation.
It is. It's one of the things that I counsel about in my pre-test counseling. So everybody has the chance to kind of get their ducks in a row.
So if you and mom and dad are going to get tested, we will get information about the true nature of your relationship.
Right.
How do you word that up front?
So we talk about a list of potential incidental findings. So one of them could be, we could find out about a type of cancer risk that isn't something that we already see represented in your family. A good example is BRCA. So if there's a strong family history of breast cancer, we didn't know that you were at risk for ovarian cancer, but now we do. Another type of incidental finding is learning that familial relationships were different. And so I will say, if we test multiple people in the same family, we could identify that someone's biological father is a different person than we were told. point blank. No room for interpretation.
And you get a blank stare or questions or a little bit of everything, depending.
A lot of times a chuckle, but
Okay.
sometimes, and it doesn't happen to me so much in cancer, but occasionally throughout my training, when we would test children who were born with multiple, birth differences or developmental differences, we test triads. So test the child and their parents together. So when you're right away going to test everybody at the same time, it comes up a little more often.
Okay. Other situations where you would recommend genetic testing besides the ones we've talked about already?
There are some types of cancer where every person with that cancer is recommended to have genetic testing. And a lot of that is driven by the chemotherapy options that are available. So for anybody with pancreatic cancer or ovarian cancer or metastatic prostate cancer, genetic testing is recommended in order to determine if they do have a BRCA mutation, because there are certain drugs called PARP inhibitors that are more effective for people with a BRCA mutation than for people without. So it can give their oncologist another piece of information in their back pocket to know what drug might better target their cancer.
Are there some genetic tests that tell you, give you information about how likely this particular person is going to respond to a particular treatment?
That's about the only one.
Okay. The other are more, there's like sort of protein analysis or other enzymes that might indicate whether you're likely to respond to tamoxifen or
those would be more probably metabolism, blood work, or the tumor profiling that you were talking about earlier.
Okay. Well, let's open it up to questions here. So we've got a live studio audience, and we also have folks that are live streaming us right now. So if you're watching us right now live, please put your chats in the chat box, and we'll also take questions from anyone in the audience. Anything you wanted to know about genetic counseling or genetic testing?
This might be a bit off subject. I mean, we're talking about statistics and numbers and percentages, but what's being done, or is it, I'm sure there's a lot of research being done to say, well, why does that BRCA gene, I mean, how does it express itself, or why does that, what's the molecular process that ends up in cancer? How far along is that, some of that research? Do you know?
In terms of why we think the BRCA gene,
what's going on molecularly that causes the cancer?
Sure. So kind of the long version of the story is that the genes that we test, including the BRCA genes, what our understanding of what they are supposed to do in our cells is stop the cell life cycle. So they are a stop sign that tells our cell to stop growing. If that gene is not working properly, then the cell will grow without control. And it can change, and it's not checking itself. So it can copy paste with errors in it. That's a tumor. So if our BRCA genes and the other genes that we test aren't working properly, there's nothing stopping the cell from growing. To back up, that is actually how all cancers develop. So it's like brakes on a bike. Over time, we can accumulate damage to one cell in our body. And we're still okay as long as one of the brakes on the bike is working. We have 2 copies of every gene. We get one from mom, one from dad. So over time, if we accumulate damage in one of the copies, it's still okay. If we accumulate damage to the point where the other copy breaks down, that's where cancer develops. And that's how all cancers develop. So if someone is born with a genetic mutation, that means that there's one broken copy of the gene in every cell in their body when they're born. So that's why they have a higher chance of getting certain cancers, and they tend to appear younger. So we know that those genes are working as stop signs to tell our cells to stop growing.
Nice.
Cool. It's a complicated question.
Yeah. And another factor is our immune system. So even we probably all, whether we have a genetic mutation or not, have mutations that happen that lead to a cancer. But if our immune system identifies that cell as abnormal, a healthy immune system may take care of it when it's just one cell and it doesn't ever get recognized that a person has that cancer. As we get older, we only have to look in the mirror to realize our cells are not as healthy. And not only does our skin sag and our hair fall out, but our immune system also isn't as strong. And that's why the number one risk factor for developing cancer is age. The older we get, the more likely we're going to develop cancer. And part of that is the aging process and the immune system just not as healthy and strong to take care of the function of killing and eradicating those cells when they're single cell abnormalities. Next question.
So are you limited in what you can search for? Do you ever discover something that you weren't looking for, or is there just a range that you have to work within and nothing unexpected is ever found?
So we test the same genes. So we, the genes that get reported on to us are going to be the same genes every time for the most part. One of the things that we can find that we don't expect is, the panels are quite large. So we could be testing someone for a family history of breast cancer and find out that they have a higher lifetime risk based for colon cancer. And we didn't see any colon cancer in their family. So we test a lot of genes at one time. We're not testing for just the BRCA genes or just the Lynch syndrome genes anytime. So somebody could potentially find out a type of cancer risk that they didn't really think about being the high risk in their family. But there is a lot of research that's always done kind of on the back end that's de-identified from the patient that kind of looks into what we know about genetics in general that doesn't get reported to us.
So Lauren, sometimes when I get the report back. So I get the report, but I also get your analysis and counseling. So we'll get something called a VUS, a variant of uncertain significance. And, it's always really gratifying when you get absolutely no mutations,
Yep.
clean, it's fine. It doesn't mean you're not at risk for getting cancer because you still are at risk, but the risk is then normal risk. But sometimes you get, there's no pathologic mutation, but there is this thing here that is a variable or variant of uncertain significance. What does that mean? And does that, should we 10 years later test again? Because maybe we now know in 10 years from now that variant is of significance as opposed to of uncertain significance.
Great question. So there are 3 possible results when we do a genetic test. A positive is when a mutation is found. A negative is when everything is normal. And then a variant of uncertain significance is when there is a change in the DNA. I call them a spelling change. I'd say that a genetic test is a spell check for our genes. So it's a spelling change in the DNA that we don't have as much scientific evidence about yet. So we don't have enough evidence to classify it as harmful, but we also don't have enough evidence to classify it as normal. We all have a lot of normal human variation that all makes us different from one another. In cancer genes specifically, over 90% of the time, those VUSs eventually get reclassified as benign. So when we get them, we don't make any medical changes with them. There's nothing else needed on the part of the patient. And on the back end, the lab and genetics as a science keeps working on what that means. They use a lot of different pieces of data. And as more people over time get genetic testing done, we can reclassify a lot of those to better.
So it
help
no
the
longer
patient.
is a VUS, it's just a negative.
Right.
And I do understand you're calling it a spell check and an error in spelling, but is it a mutation?
It is not. Mutation is a term that is specifically reserved for a harmful variant, a harmful change in a gene. So the mutations are what we call it when it is increasing someone's risk for cancer.
Gotcha.
Yep.
So a mutation is a spelling check,
Yep.
but it's a spelling error, but it's one that we know leads to disease.
Right.
So that's calling it a mutation.
Right. We call them, so variants are kind of the blanket word that are used for all the different changes we can see in genes. And they are on a scale from pathogenic to benign. Pathogenic variants are what we call mutations on the daily. Benign variants don't even get reported on tests. They are normal human variation. And then right in the middle is our variant of uncertain significance. So we don't have something to tip the scale.
Okay, great. Thanks for clarifying that. Other questions from, here we go.
So before a patient were to come to you, I happened to be a day where I went into the office, I met with my surgeon, and you were there. So then it was boom, boom, boom. We had a blizzard going on too. So it was just like, yes, let's meet and get it over with. Some of it threw me off. I did not know my family history like I thought I did. And it's very embarrassing. And it's hard to remember aunts and uncles that you never met because they had died. So what would you recommend to someone before they come and see you to prepare?
Sure.
Like, I feel like you almost need to do a homework. And then my friend that was with me, she immediately went and got all of her ages of her aunts and uncles, that their births, their deaths, and started preparing a nice family tree, genetic tree, in case she needs it in the future.
Sure.
Or her children need it.
Sure. Well, that's a great question. And for the most part, many people do have the chance to submit some family history online. Sometimes we're trying to, do right by the patient in a convenience way and do all those appointments the same day. And so you can be a little thrown off because it's not top of mind that day, especially. So we do recommend that somebody, take some time, talk it over with a family member, especially a family member in a different generation, because there's actually statistics reported that say if you have somebody from another generation talk over the family history with you, you get like significantly more accurate data. So take some time, talk it over with your family. And I think that some of the big questions to ask that I'm going to ask a patient are, how many people were in your family? And Dr. Deming almost touched on this earlier, saying, it's different if 3 of your aunts have breast cancer and you only have 3 aunts, or if 3 of your aunts have breast cancer and you have 8 aunts on one side. So talk it over with your family about who's all there, how old they were when they passed away, if they've passed away, if they were diagnosed with cancer, what age they were when they were diagnosed with cancer. Someone does not have to die of cancer for it to be important to me. That's kind of a common misconception too. So somebody could have cancer at a much younger age and then pass away later of natural causes, which makes a difference to me. So ages of diagnosis, ages they passed away, as much information as you can get about what type of cancer they had, and perhaps anything about their treatment. So I might ask if someone had prostate cancer, if if it spread to any other parts of their body or was metastatic. So those are the kinds of questions that I'm going to be asking somebody in their family history part of the session.
Great. Any other questions? We have time for one more question.
Is getting cheaper and cheaper, or is it something that just stops people in their tracks and they can't do it because of the cost factor?
It's certainly getting cheaper and cheaper. At least once a week, I'll still have somebody say that their doctor told them it was going to be thousands of dollars. And I'm here to tell you it's not. It's almost always covered by insurance. There might be something towards a deductible or a copay to meet. And then the labs that we work with also have really competitive patient pay prices, where if you didn't have it go through insurance at all, the cash price is $250 for most of the labs that we work with. So it's a good anchor to have, just to know that we've got an option at some point, and genetics is not an emergency. So if the cost is the concern, we'll work with you to get it lowered as much as possible.
Excellent. So Lauren, thanks so much. It's been really informative. Thank you for being part of our team, and thank you for being such an articulate spokesperson and explaining what genetic counseling and genetic testing is.
Thanks for having me.
Thanks, everybody, for coming, and please join us again next week. Again, I'm Dick Deming, Medical Director of MercyOne Cancer Center, and come and join us again next week. If you know someone who would benefit by listening and watching this program, tomorrow it will be available on demand at the Above and Beyond Cancer YouTube channel and also at the MercyOne Cancer Center website. So you can watch it again at your leisure on demand. We'll see you again next week. Thanks, everybody.